right, can you just go ahead and spell your name, please?
Holly Rehder, Rehder.
All right. And then the first question I just want to ask is, can you describe the basis of the PDMB bill that just got passed and its goal?
Okay, so the basics of the Dr. Schaaf bill that just got passed, the SB 74, I believe it is that the state would have a PDMP, but it's not a true PDMP. It sets up, the pharmacists put the information in, and so that information is then held at the department. And so then when a physician writes a prescription and then that person gets it filled at the pharmacy, it sends back a red light, yellow light, green light, and so based on prior prescription history. Now, the difference between that bill and the bill that I carry, House Bill 90, and then the bill that Senator Schatz is carrying, because he and I have the same bill, his is Senate Bill 314, is that ours is a true PDMP like all the other states have, so that your physician can actually query the system for his patient. Now, it is covered under federal HIPAA law, so a physician can't go look at their neighbor's medication history. You know, they can only look at their patients. But what PDMPs do is they help physicians spot early signs of addiction, and also be able to tell if maybe the patient's psychiatrist had given them medication that might counteract with the medication that the physician's going to give. So it really just gives that physician more information about their patient so that they can make the best clinical decisions.
Right. And I do question the effectiveness of that bill as well, too, and I know you did as well. Can you just basically explain why you oppose this bill that just got passed?
Right. So my main sticking point is the same as Senator Schaaf, so we're just on opposite sides of it. He doesn't want the physician to be able to see their patient's medical information, which to me makes no sense. I think the physician must be able to see their patient's medical information, narcotic use, because the physician is who you want. You want your medical professionals to make those decisions for you. You want your medical professionals to be able to tell if you're starting to show some signs of addiction, and to be able to help, get you back to a better path in life so that you can be happy, pain-free, but happy, but not addicted. And so all of those decisions, physicians are the ones that go to school, that figure this out. They're the ones that need to be working with their patient, not someone from the department.
Right, and I feel personally too, exactly, that it's a big invasion on privacy on the doctors as well, if they can't go back and see that medical records, and it's just, so what has this past person done if you can't see that?
Right.
And I know it dated back that those records can only be kept for 180 days. Is there any way you can explain that just a little bit more, or is it just set in stone on that?
No, his bill is not set in stone. All of the medical associations and the majority of the reps and senators agree with my version and Senator Schatz's version. Senator Schaaf did not have one association testify in favor of his bill. He didn't have one person testify in favor of his bill. And so his is a program that he's thought up, and I appreciate him thinking on this, but it's not a program that's ever worked, and it has a $6 million price tag when we're in a deficit in the state right now. And and we have half of Missouri's population already covered in a county that's passed a PDMP. So his bill would circumvent what the counties are already doing, and honestly, that's what he's trying to do. He doesn't want the counties are giving physicians access to their patients' medical narcotic use. He doesn't want that. And so his bill would circumvent what all of these counties have already started working towards. And so we're just, no bill would be better than allowing his to pass.
Exactly. Okay, so then moving on to more, we talked about more Missouri-wide. I just want to focus on more locally. Do you think that doctor shopping exists in Missouri and let alone Springfield? Because I know that was the big basis of this bill getting passed, is to track and stop those doctor shoppers so it wouldn't happen anymore.
To Dr. Schaaf, that's the big deal.
Right.
To me, that's not the big deal. It's a very small percentage, doctor shoppers. However, it is typically those that are addicted or dealers, and so we definitely need to stop that. And I think in the overall scheme of things, it's a very low percentage that actually doctor shop, but it does catch that. It does stop it. And my main concern is that PDMPs help the physician spot signs of addiction. And what we have is 3 out of 4 heroin users started with an opiate addiction. So what we want is, we truly want our physicians, our medical professionals, to catch addiction on the front end before they've moved to heroin. Before the babies have been taken away from the mama, before somebody's in jail because they've now lost their job and started doing things that were illegal to be able to get their hands on opiates. It's very much a process, and that's what it ends up in. And so we had over 6,000 children removed from substance abuse homes last year. And so the fiscal note on the state is huge on ER expense. Just people going in shopping for opiates and in the emergency room saying they've fallen and hurt their back or they have a toothache. All of these type of things would be caught if the physician could look and see, okay, you were at the emergency room 2 days ago and got a 30-day supply. There are just some things that we need to stop. But the most important part to me is that physician being able to have that conversation with their patient about the signs of addiction, and then the things that they can do to start moving back to a healthy lifestyle.
And then to further off that, when I was researching this story more and the bill being passed, they claim that the Missouri Department of Health and Mental Services claim that about estimated 230,000 Missourians misuse drugs. Would you agree with that fact, more or less?
I've not seen those numbers, but I know that it's extraordinarily high.
And then the opiate deaths keep increasing as well too. What would be your best course of action to, I guess, prevent that and decrease those numbers?
Yes, I think that giving doctors the access to see, because a lot of this is, I have a friend that his son overdosed on Xanax, and he was taking Xanax, which slows you down, and an opiate, and so he was taking lethal combinations, and those are the type of things that we need our physicians to be able to see, that they've gotten medication from here, to help prevent those overdose. But then also, heroin in St. Louis alone has skyrocketed, and it's now mixed with fentanyl, and one hit can kill you, and you don't even have any idea. But you move to heroin because you've already been addicted to the opiates. So I think that a PDMP will absolutely slow down our overdoses. Florida had 50% decrease in overdoses when they kicked their program into high gear. And so in California, 74% of physicians said that they changed their prescribing practices once they had that information. And so, that 74% of physicians saying, we would have prescribed something differently had we not have had this. And so it's good clinical use for the doctors. And this is something, Missouri just has antiquated medical laws. For us to think that a PDMP is a problem when all the other states are doing it, California's been doing it since 1939.
Right, I know, and I was researching more too, that we were the only state not to have any monitoring system, so this was a big step for us in general. Right, and then I guess so my next question is, I want to focus now locally, do you think is it a problem here in Springfield, and what impact do you think it will have, if you know by any chance?
In Springfield is the same as from where I'm from. I'm from Southeast Missouri, and so we're in the other corner of the state, which is, encircled with states that have PDMPs. You guys over here in Southwest Missouri, you have Arkansas, you have Kansas, you have Oklahoma, all that have programs. In Southeast Missouri, we have Arkansas, we have Tennessee, we have Kentucky, and Illinois that all have programs. And so we get an influx from those states of people coming over here to get a prescription, to fill a prescription, because they can't do it in their state without being tracked. Yes, and so it's a huge problem. Law enforcement says it's a huge problem. They stop folks all the time that are doctor shopping and that are over here. And I mean, I think that it most certainly would help. I mean, it increases crime.
Yeah, it definitely does.
You know, I mean, there are just so many things. You know, child abuse.
Right.
I mean, there's so many things tied to this that, I mean, the PDMP's the cornerstone of fighting the opiate epidemic, and in Missouri, we don't even have that.
Right, nothing. And then to further off that question, what age demographic do you specifically think that this generates towards the abusers? In my eyes, I personally think it's the college student range, 18 to 25, and as I was researching it too, because most people say it's the same, and I get firsthand impact on it because I'm here at college and I see that people are just getting easily access to Xanax, like you said, and that's a big common overdose. So I just wanted to see what your input is on that as well.
You know, I think so. And what we have is when teenagers, you know, start wanting to use something recreational, a lot of times, you know, when I was young, it was drinking, it was smoking pot. You know, well, when you take an opiate, your parents really can't tell. And when you take Xanax, your parents really can't tell. And so we have our high school students who, with a sports injury or getting it out of mom's medicine cabinet, you know, try these out and then just start buying them, and they don't want to. They don't want to get off it. It's painful to wean yourself off of these, so they don't. And college students, yes, and you know, and a lot of times I mean,